Western Pacific region. Welcome to Strengthening Climate Resilience and Sustainability of Health Systems in the Western Pacific region. And today's session, the diagnosis, climate change risk assessment for health systems. And I'm Thanazile Swindi. I will be your facilitator for today. Before we begin, we would like to acknowledge the course organizers. We have the Western Pacific Network on Climate and Health Education, the Global Consortium on Climate and Health Education, the University of Sydney, Oceania Lancet Countdown, the Planetary Health Philippines, and the Sync Health Jew, the Global Health Institute, and all the organizers. And for the closed captions, today we'll be having the closed captions. For English captions, you need to click on the screen, the CC at the bottom of your screen for you to be able to access the closed captions. And then for Mandarin captions, you need to click in the chat. There is a link that has been posted in the chat. You can also get an English transcript of the session from that link. And today, the course objectives are to articulate or communicate to key partners and the public how uncertain climate futures are likely to have different demands on the healthcare systems and how health systems contribution to climate change. Apply methodology and frameworks for assessing vulnerability and adaptation for health systems in the local context. Apply approaches for measuring and monitoring the environmental sustainability of health systems and health core benefits of transitioning to green health systems. Apply a health equity lens into efforts to address health system decarbonization and climate resilience, and also to enhance climate and health leadership action. This course has got 10 sessions, and today we are on session 2, August 27. The session is entitled The Diagnosis, Climate Change Risk Assessment for Health Systems. And the course session for today, the objectives of today's session are to explain the concepts of climate change and health vulnerability and adaptation, assessment and its role in strengthening health system preparedness and resilience, to identify and apply relevant frameworks and methods to conduct a climate change and health vulnerability and adaptation assessment. The third objective will be to collaborate and engage with stakeholders across sectors, for example, water, infrastructure, agriculture, urban planning, energy, and health, to support integrated risk reduction strategies. And for you to earn a course certificate, you need to have attended at least 7 out of 10 sessions and pass the final examination with a score of 70 or more % at the end of the course. And your participation in this course is automatically recorded each time you log in, and the examination must be completed using the same email address that you are using to attend the Zoom session, and the link will be given to you on the final day of class via email or WhatsApp, and it will close on the 29th of October at 11:59 p.m. Sydney time. The format of the exam will be about 25 multiple choice questions, with other questions being true or false, and participants should be prepared to take the examination in one sitting. And for today's session, it's going to be 90 minutes long. It will include expert lectures and case study presentations. The sessions will culminate with a question and answer session, so be sure to put the questions in the Q&A box. The session videos and recordings, slide decks, and resources will be made available on the course website. And for attendance is automatically recorded during the live Zoom sessions. Your individual attendance is only counted if you join using your personal Zoom link, and your attendance is not counted if you join with a colleague's link. So make sure that you are using your personal link to join in. YouTube's reviews will not count towards attendance. And you can also follow the course through this WhatsApp group. If you have already not joined the group, you can scan the QR code, or you can click on the link that has been put in the chat. And for presenters for today, we have Dr. Roheda. She is the head of Environmental Health Research Center at the Institute of Medical Research, National Institute of Health, Malaysia. She has served as a public health medicine specialist in the Ministry of Health for Malaysia for 17 years, where she has developed extensive expertise in environmental and occupational health. Her core areas of work include health surveillance, risk assessment, and vulnerability and adaptation assessments, with a strong focus on the intersection of climate change and health. Her research interests span climate-related health risks, the health impacts of environmental degradation, toxicology, and work-related non-communicable diseases. She plays an active role in several national research initiatives, including the Children's Environmental Health Birth Cohort Study and the National Human Biomonitoring Program, both of which generate important evidence for protecting vulnerable populations. She also served as the public health sector lead author for Malaysia's 4th national communication to the UNFCCC, providing critical inputs on health-related vulnerabilities, risks, and adaptation measures. This role reflects her leadership in advancing evidence-based policy and strengthening Malaysia's response to the health impacts of climate change. Beyond research and policy, Dr. Roheda contributes to national capacity building in environmental health, working closely with policymakers, healthcare providers, and researchers to strengthen preparedness and resilience. We also have we also have Dr. Emma Porio. She is the project leader and principal investigator of the Coastal Cities at Risk in the Philippines, Investing in Climate and Disaster Resilience Project. She is the Professor Emeritus at Ateneo de Manila University and a Science Research Fellow at the Manila Observatory. Dr. Porio also serves as a co-chair of the Philippines National Panel of Technical Experts under the Climate Change Commission, Senior Resilience Fellow at the National Resilience Council, and the lead author of the UNFCCC IPCC Climate Change and Cities Report for 2027. And also in the panel, we have May. She is a PhD research fellow at the Planetary Health Program of the SingHealth Juknas Global Health Institution, the Juknas Medical School, National University of Singapore. May commenced her career as an environmental scientist, focusing on the impact of climate change on drinking water quality along Cambodia's Mekong and Ton Sap rivers. Armed with a PhD in climate and health geography from the University of Western Ontario, her research broadened to encompass global health challenges, particularly emphasizing the health impacts of climate change and adaptation strategies in coastal Cambodia. Her interdisciplinary expertise spans digital health, communicable diseases, maternal and child health, and non-communicable diseases. She is also overseeing climate health projects in Cambodia, Indonesia, Singapore, Sri Lanka, and the Philippines. We would like to welcome all our presenters for today. Thank you. I now call upon Dr. Roheda to give us her lecture.
Thank you, Tandy. Everyone, good day. Let me share my slides first. Basically, there's I think I scroll upon the participants today. There's participants all over the places, and thank you very much for joining us today. So this lecture or presentation is about the vulnerability and adaptation assessment. So climate vulnerability and adaptation assessments in health systems resilience. So I will brief today about the introduction to climate change and health. Secondly, on the health systems resilience, and thirdly, about what we are doing in Malaysia, especially on the health vulnerability and adaptation assessment, and the next about the cross-sectoral involvement beyond the health sectors. And for the introduction, we know that the climate change is the greatest challenge of this century. And with the global warming that happened, with the increase of temperature for more than 1 degree Celsius over the past 100 years, and coupled with extreme weather events and other environmental degradation, especially the pollution that directly and indirectly impacted the ecosystem and human systems. So climate change has increasingly affected human health through the shocks and stresses, such as in certain events that, for example, flooding, storms, wildfire, that is being said that the climate change impacts coming from the increased temperature, increased precipitation and rainfall, and also sea level rise, and the stresses from the long-term pressures from the heat waves, coupled with, for example, the climate variability such as El Nino phenomenon, making the hot weather and heat waves unpredictable, being increase in intensity, increase in frequency and duration. And it causes impacts, especially the dry spell that cause water scarcity. And if you look at the diagram on the health impacts of climate change and the potential impact reduction through the adaptation, which was reported in the Intergovernmental Panel for Climate Change in the Assessment Report 5, looking into the three scenarios at current scenario, and then the next 5 to 15 years, and up to 2100. And if you look at into this diagram, at current level, actually the red chart would be that there's a risk level at our current level, our current scenario, but the potential for adaptation will reduce the risk. But then if the temperature increase for the next 5 to 15 years up to 1.5 degrees Celsius, the human system would be very much affected. The increased number of cases such as vector-borne diseases, food waterborne, the impacts through the heat and air quality, and also undernutrition. These risks would be very much remain at certain level, even though we start to implement high adaptation, and worse for the next 100 years up to 2100, when the temperature, let's say that with current adaptation that we are doing nothing much. When the temperature reaching the additional 5 degrees Celsius, probably more than 50% of our population will be perished. So there's a challenge into our healthcare systems, especially when we are looking into the impact of climate change, whether from shocks or stress, or from the climate change coming from increased temperature, increased precipitation and rainfall, and also sea level rise. But we don't look at the climate impacts. We should look at more what we are contribute in the healthcare systems. For example, the consumption at our healthcare systems, we are using energy, we are using the chemicals, and we are producing more waste in our healthcare settings, and this contributes to the climate crisis. So what have been looking into at the global level is that the resilient health systems. We're talking about how our healthcare facilities can reduce the vulnerability. We can strengthen our healthcare systems capacity, and we could respond and adapt to better recover in facing the climate change. So if you look at this diagram from the WHO 2015, we are looking into the challenge of the climate change, either from shock or stresses. And the capacity to deal with the exposure from the climate change, I think we all know that we are looking into the vulnerability, either from the exposure and also sensitivity. And to increase the adaptive capacity from our healthcare systems in order to achieve better, to transform, at least we can recover to the baseline state. But if we are doing nothing, we could be recover worsen than before, and also the collapse of how our healthcare system. We could not sustain our healthcare services to our population, especially the vulnerable populations. So what is the healthcare resilience, health systems resilience? It is the ability to anticipate how we are responding to cope with and to adapt with the climate exposure, either the climate shocks or stress, while we will be able to provide uninterrupted healthcare services. So that's why we are looking into the vulnerability of our health systems. The vulnerability that is the concept that include the sensitivity and susceptibility of our health systems in terms of giving the capacity to cope and adapt. And adaptation, when we are talking about adaptation, meaning that for example, at current level, we're already facing climate change with certain scenarios. So at the moment, in certain areas, for example, some communicable diseases, vector-borne diseases, and food-water-borne diseases are already being a very major public health challenge. So what we are doing to adapt to the current scenario. So we need to do some adjustment for better public health intervention in order to reduce the impacts from the climate change. So if you're looking back at the facility as a system anchors, I would like to share about the 10 key components of climate resilient health systems. It was introduced by the WHO in 2015, where we are talking about health facility not as in isolation, but the health facility that could sustain its services, not only about the medical or health services, but also in terms of other support systems within the health services. So what is important about the resilience? Because when we implement some sort of resiliency for our healthcare systems, it is an intervention that directly informs and also to strengthen the public health policy and programs, either at the local level, national level, and also regional level. And also being said that we are going towards the climate resilient health systems, we are talking about how we are going towards the National Adaptation Plans, or NAP. And it is, I would say that it is a compulsory plans to all those countries that ratified under the Paris Agreement 2015. So, for example, some of the Southeast Asia country already coming up with the national adaptation plans, and they have already included a national adaptation plan as part of their national programs. So this is some glimpse of the climate resilient health systems as a framework. For example, from the first about the leadership and governance up to the 10th key indicator as the climate and health financing. But what we are going to talk today are more towards number 3 about the assessment, how we do the vulnerability and adaptation assessment, how we map our healthcare facilities to develop the baseline indicators for our health systems, and to define what more can we do for the health systems. But apart from the number 3, the vulnerability and adaptation assessment, it comes together with other components as well. For example, the health workforce, number 2. Do we educate? Do we increase or giving some rising awareness to our health workforce about the climate change? Do our medical doctors, do our nurses, do our health officers or environmental health officers aware about the climate change and how we can contribute as an individual or as a department, and working together with the community to increase the awareness of the community? And what I'm telling my colleagues from other division, for example, we do have a good early warning systems, especially for certain diseases. Our good programs on the surveillance on, for example, the vector-borne diseases, the dengue, malaria, which very much related to climate change. But do we integrate our informations, our data with the environmental health, environment data, with the meteorological data, that looking into the modeling and prediction for climate change? And we are working together with other sectors, for example, the engineering program in terms of infrastructure, and with the financial for the climate and health finance, and other components as well. So when we are talking the current movement of the vulnerability and adaptation assessment at the global level, especially in the Intergovernmental Panel of Climate Change, or IPCC, we are moving from the basic VNA, vulnerability and adaptation assessment, to the CRVA, the health, climate risk and vulnerability assessment. This process would start as to identify the climate hazards. What hazards that we have? I will explain in some of the example from Malaysia. So what do we have? The heat waves, the droughts, flood or storm surge, wildfire, toxic haze, sea level rise, or the patterns in the vector-borne diseases especially. And then looking into the exposure and vulnerability, how our systems, especially when we are talking about health systems, our facilities, our health workforce, the communities, and also the support system, especially the supply chain to our health systems, and then the sensitivity, the system's susceptibility to the shocks, and how we are dealing with the current impacts of climate change in terms of our coping ability, and how we strengthen our infrastructure and also utilities to ensure that we can cope better with the current scenario. And the climate risk, we're talking about how the risks are, which equals to hazards times exposure times vulnerability. And this is aligned with the latest IPCC assessment report number 6, which looking into the interaction of the risk of the hazards, exposure, and baseline vulnerability, and how when we identify the climate risk, how we prioritize the risk. Probably not all countries are looking into the same risk as, for example, in Malaysia, our risk we might saying about the dengue disease, the dengue as compared to malaria, because, for example, in Malaysia since 2017, if I'm not mistaken, the human-to-human malaria was actually reported as 0 since 2017. So we're dealing with probably different risk as compared to other countries, and how we determine our next step into reducing the climate risk by adapting well, by strengthen our resilience towards climate change. So this is, for example, what we have done, because I'm coming from the research wing from the Ministry of Health Malaysia. This is our study on the vulnerability index tool for assessing levels of climate resilience in healthcare facilities, and we call it a vital healthcare facilities. This was published this year, I think in May this year. So we do some development adaptation questionnaire. We review the current framework of climate vulnerability and risk, and we adapted the tool from the WHO healthcare facilities checklist, because even though the WHO has provided with some checklists of the vulnerability and adaptation assessment, it should be adopted based on our different culture, different geography, and also different public health issues. So we are validating the questionnaires that looking into the index. So in Malaysia, even though from the WHO guidelines, they are looking more, for example, into the dry spell, into the cold surge, and others. But for Malaysia, we are in our study, we're looking more towards the hot weather and heat wave trends, because looking back for the past 20 to 30 years, our mean temperature, especially in the Peninsular Malaysia, has increased about 0.24 degrees Celsius for every decade. So our next issues or exposure on climate is coming from the increased rainfall, the sudden shocks because of the flooding. So for the past few years, we have suffered infrastructural damage, especially to the healthcare facilities, with some millions of ringgit in terms of the loss of some assets, some instruments, and this we are looking towards how we can improve our healthcare facilities in adapting or coping towards these two scenarios, the hot weather and heat wave, and also flooding. So we are looking towards the exposure sensitivity and adaptive capacity, and coming up with a vital HCF tools for assessing the vulnerability and adaptation index. So for example, for exposure, we're looking towards 12 indicators from how our healthcare facilities prone for flooding and also to the sea level rise, as well as hot weather and heat wave. And some of the data, for example, if you can see the number 5, I think number 5 up to number 12 is coming from the secondary data, coming from other agencies, the meteorological departments, especially on the number of floods, the precipitation or rainfall data. We are looking towards the hydroclimate projection for both inland flooding and coastal flooding coming from the sea level rise. And also we get the data from of the temperature on hot weather and heat wave, and we are looking towards the sets of data and also including the relative humidity. And for the sensitivity, it's more towards the facility characteristics, and then the healthcare workforce, the staff infrastructure, and also the services. We'll be looking into the infrastructure, for example, the building age, number of stories, and then the population coverage and our capacity from our number of doctors, our number of specialists, and type of hospital, and average number of patients coming into our healthcare facilities, including the bed occupancy rates. So we are also looking towards the infrastructure. So lastly, the adaptive capacity. There's 4 elements of adaptive capacity looking into the health workforce: wash, water, sanitation and hygiene, and waste management. Thirdly, on the energy services, and fourthly, on the infrastructure. So how we do the index? So this is based on the vulnerability index calculation. B is for the vulnerability. It is equals to exposure index. The exposure that I have shown you, the 12 indicators, and then the sensitivity coming from the indicators from the sensitivity. And plus 1 minus adaptive capacity. So it is being tabulated as an index. So we are giving, for example, for exposure and sensitivity, the index would be classified or categorized as categorical data or numerical data. And for numerical data, we do some normalization. So we decide how we are going to give the percentage of the points for each answer that are being responded by our healthcare facilities. But for the adaptive capacity, it is based on the WHO tools, either from the response, or what we could say the preparedness of healthcare facilities, from unprepared to the best prepared facilities. So the index will be from 0, 1 and 2. So we are calculating this and coming into the index level, either from low to very high, so that we can map our healthcare facilities for their for their vulnerability and also we could say resilience to healthcare facilities. The example from the geospatial application on the maps. So this is actually from our paper on the pilot project that has been done in 3 healthcare facilities. This is the map for the Peninsula Malaysia. Malaysia is divided into one part of Peninsula and another part the Borneo Island. So our population are actually mainly at the peninsula part of the peninsula of Malaysia. So we did our study at the Klang Valley. It is the most populous region of Malaysia. So we are looking towards the index from the exposure, adaptive capacity, and we are comparing this index so that we can identify which facility are giving lower index of vulnerability or higher index of vulnerability. For example, the maps on the right side showing the first are the heat wave vulnerability index, facility A and also facility B showing medium to high vulnerability. So we need to focus more on these facilities so that they can improve the adaptation towards climate change. And the next is the vulnerability index for flooding for those 3 facilities, showing that most of the facility actually showing low vulnerability index, actually from medium to low vulnerability index. So that's why we are coming out with some index so that our programs could plan more on the adaptation of climate change. And these vital healthcare facilities are currently since July 2026 are being used by the Ministry of Health Malaysia for healthcare facilities where we are currently starting to assess our healthcare facilities. And then another example is the community. Apart from the healthcare systems, we're looking towards the community vulnerability. So there's a lots of tools on the vulnerability index, but we're moving towards our most vulnerable population, the island community. So we did come out with a vulnerability evaluation tools. We call it ICO. That we are developing the questionnaire to assess the vulnerability index for small island communities, because when looking back into the vulnerability index for communities, mostly are about the socioeconomics, about the finance, and then the economics of our population. There's a limited study, limited tools about the health vulnerability towards climate change among our population. So this is our validated questionnaire we have recently published in 2025. So we identify our small island based on the population, based on the size of the island, and also for certain number of people who are inhabited the island. We have around, in Malaysia, we have more than I think nearly 100 islands, small islands, but not all are actually inhabited. So we have around 31 small islands that some of the populations are living there. So we identify the exposure, sensitivity, and adaptive capacity, the first inner side of the diagram, the circle. And then from that, for example, for exposure, we are looking towards the nature of exposure and impact of exposure. For the sensitivity, the components will be demographic, the health, and socioeconomics, and adaptive capacity in terms of social capital, human capital, physical capital, and adaptive behavior. So out of all the indicators that we are looking, we have linked with the health-related indicators, which are related to water access and water quality. It is a very important aspect of population living in small island, because there's issue of water supply, especially for drinking water, the quality of drinking water, and how do they practice treatment of water. And for the healthcare access and utilization, especially how they are choosing the mode or type of treatment, whether they are still choosing traditional or modern, we would say medical services, and have status, especially on comorbidity and physical disability. So this is how we come out. We did a survey in 2020. I think it's around 1 year study from 2024 to 2025 in 5 small islands. If you look at the map, on the left side will be the Peninsular Malaysia. So we do study on 3 islands at the east coast of Peninsular Malaysia, from the 2 at the northern parts, and 1 below towards the southern parts of Peninsular Malaysia, and another 2 islands at the Borneo Island. Borneo Island will be a large island, but we do the study at the Mantanani and Gaya Island, which being included in our study as part of small island. So basically, if we are looking towards the household vulnerability index, we could say that actually 1 in 4 our household have shown high vulnerability index score. So it seems about the same as the healthcare vulnerability, where we calculate based on the exposure plus sensitivity plus 1 minus adaptive capacity divided by 3. So this is how we come out for each household, and we can average for each islands. For example, the Mantanani Besar and Gaya, the one with the green, actually showing moderate to high level of vulnerability index. So what important from this vulnerability and adaptation assessment tools, the ICOV, that we able to identify and prioritize the high-risk islands, and especially about the main problems in small island communities, the access to healthcare facilities, the pre-existing comorbidities, and the issues of water supply. So how we are going to intervene using this data, working together with other agencies in terms of targeting the interventions on the outreach for the population, and to embed the climate health vulnerability screening in our public health programs, and to continue the monitoring, and also to ensure the adaptation are being implemented well. So what is important actually for the vulnerability and adaptation assessment? First is the diagnosis, to identify the hazards, to assess the vulnerability, and to project for future risks. And it is important tools in terms of the national plan for climate change, the Health National Adaptation Plan, to integrate in the current policy to ensure that we can achieve the target, we can define the targets and to achieve it, and to ensure the cross-sectoral involvement with other agencies, and lastly to ensure the to prioritize the resource in terms of funding to ensure to achieve the cost benefits and capacity buildings for the healthcare systems and also community. So as we are going through all those assessments, we are aware that health systems, we cannot working alone. We need to have reaching for other sectorals, especially in terms of the energy sector, the infrastructure, water sector, and urban planning, so that we can continue the operation to ensure that the governance and also the intervention are being implemented well, both for health systems and also the community. So as a conclusion, we are currently dealing with, climate change is already happening, and it could be worsened if nothing being done at our level, the individual, community, and also up to the national and global. So we need to transform our health facilities. It is a compulsory, it is not an option to enhance the health access for our communities, to strengthen the community resilience, also to integrate the multi-agencies involvement in terms of protecting our health, the population's health in the changing environment. Okay, that's all for my presentation. Tandy, I pass back to you.
Thank you so much, Dr. Roheda, for such an informative presentation. And climate change is indeed a century-defining threat. And thank you for the tools that we've just learned on that we can make use of as we assess the vulnerability and adaptation of our institutions. So for now, we move on to call upon Dr. Emma E. Porio to give us the case study that she has for us. Thank you.
Thank you. I will just share my screen. Just a moment. I'm not sorry. Okay. Can you see my screen now? Hello?
Yes,
Hello?
we can.
Yeah, okay. Thank you very much for inviting me here. I'd like to thank Maggie and team for organizing this excellent health forum. Good day, everyone. My presentation is titled Diagnosing Climate Risk at the Front Lines, Building Resilient Barangay Health Systems in Metro Manila's Informal Systems, Settlements. I would like to share with you what I've learned from several studies that I've done on Metro Manila's informal settlements during these past years, especially during flooding. Our central question is simple but urgent. When floods, extreme heat, or water disruptions occur, especially in informal settlements, can people still obtain essential health care? I will argue that resilience must be built from the lowest political administrative unit, the barangay, upward, because there is where climate hazards become immediate health emergencies. Let me first share with you Metro Manila and Philippines climate change context and vulnerability. These are the coast, if you look here, these are the coastal inundation maps of Metro Manila on your left and Metro Cebu on the right. It is projected that by 2050, these are the coastal inundations of these two cities. Actually, I always tell people we do not have to wait for 2050. Heavy rainfalls cause tremendous flooding to our cities. If you see there in the middle map, it shows that 64 of the 81 provinces and 54% of the 1,610 municipalities and developments are already affected by sea level rise. The risk of sea level rise is really very, very crucial, and I will tell you later, especially like we always say, Philippines is sinking 3 times the global average, and subsidence and sea level rise accounts for that. Let me show you the Metro Manila's socio-political economic profile. Metro Manila is a dense and population complex urban region. It has 15 million population. Daytime is 16 to 18 million, but Mega Manila is now between 25 to 30 million. And this place alone, if you look here, Metro Manila and then the surrounding Mega Manila, they account for almost 60% of the nation's GDP. So urban economic primacy and risk governance issues are very important. Metro Manila has 17 cities and 1 municipality, and governance is quite fragmented. Informality is 40 to 60%, with many households living in insecure housing, low access to basic services, and limited community facilities and infrastructure. So as I was saying earlier, these conditions mean climate risk is shaped by inequality, land pressure, access to services, and uneven capacity to respond. So we should start from the barangay. When flood waters rise, does care still work? I always say a healthy facility can be standing, but the health system can still fail. So we should not ask ourselves whether the barangay health center is flooded. We should ask whether people can reach it, whether health workers can reach the residents, whether clean water and electricity continue, whether medicines and vaccines are protected, whether referrals work, and whether surveillance continue. So we should anchor our discussion on why these issues matter. This matters because Metro Manila faces a compounding multi-hazard systems problem. Philippine temperatures have risen, and future warming and changing rainfall patterns will intensify pressure on already stressed urban systems. Flood management progress is important, but project indicators should not be confused with full measure of climate health risk. We need a systems-based approach that links food management with transport, solid waste, land use, water, and health planning. So let's look at the framework one on climate health risk that I'm proposing. Climate health risk emerges from the interaction of hazards, exposure and vulnerability, and capacity equals resilience. So what capacities do we build among CCADRM scientists, professionals, practitioners, and most of all the people to reduce their exposure and vulnerability to the impacts of floods, rising seas, and all. We have to contextualize and localize each component of the community health risk profiles and see that the same flood depth can have results differently across different barangays. So the framework two that we should look is that We should not map urban poor as one undifferentiated group. Urban poor is a broad category for effective climate health prioritization. We have to look at one, the place, two, the people, structure, and services. I should say that my work in Metro Manila show that place-based vulnerability and sector-specific vulnerability interact and intersect. That's why a single hazard map is not enough for health systems, decisions, and community resilience. For example, the impacts of flooding to a low-income household with one lactating mother, let's say 4 children, one with disability, a father with intermittent constructive work, a sickly grandmother, and living in marginal riverine settlements matters because they interact. Thus, security of housing and tenure, documentation and political voice influence access health services and the cold things that we must be worried about. So, people, places, power, structures of power and services are very important because water, sanitation, drainage, transport, and healthcare are determine whether people can cope. Risk maps show where vulnerability is concentrated. Intersectional analysis tell us why it matters and for whom. Okay, so let's look at the method. I propose a 5-part barangay climate health vulnerability adaptation assessment. One, we have to characterize hazards such as flooding, heat, storm surge, and water disruption. Second, we have to map the exposure of these facilities and people and other community infrastructure. Third, we have to trace the sensitivity by asking what fails when a hazard occurs. Fourth, we have to assess the capacity, including personnel, supplies, communications, transport, and community organizations. Finally, we identify urgent, equitable, and feasible gaps to address. If you look at this map of Metro Manila, wherein we map the shifting patterns of informality and vulnerability, you'll see that the city started from a little bit greener then to browner, and if you can see in 2018 and 2020, the dispersion of vulnerable people seeking available services and income generating activities dispersed over the city. So we have to think of this dispersion of vulnerability in terms of the services that we must have. Community-based monitoring is essential because formal data sets alone miss everyday conditions. So for example, in this one, we map that bottom 30% of the low-income households, and we map in where they are in space so that services can be delivered right away or directly. So you will see that local monitoring can identify households with limited access to toilets, safe water, people with chronic illnesses, vulnerable older residents, and areas where drainage or waste accumulation creates health risks. It is useful for barangay level decisions. So here we use the community-based monitoring system to map the location of the bottom 30% of the low-income households with barangay health workers to access and deliver health services to poor women and men, elderly, and PWDs. So you can see here also in the tool 1 that we must map not only from the level of facility but also to health system risk mapping. We use special layers to reveal where hazards, vulnerable people, and critical services and lifeline converge. This one is the Tansan community participatory map that I made several years ago that tells you where the informal settlements are, where are the facilities, and where are the waterways and the like. So you will see that The mapping will combine layers of hazards, health assets, vulnerable populations, and lifelines. Health assets include barangay health centers, pharmacies, evacuation sites, and referral routes. Lifelines include water, electricity, roads, transport, drainage, and communication. When these layers overlap, they reveal the health hotspots, places where a hazard could disrupt care for people with the least capacity to absorb the impact. So you will see that in tool 1, we have to go beyond mapping beyond the building and infrastructure. We have to trace the cascading failure pathway. And then if health system map becomes a decision-making tool when it explains how one disruption propagates through care. So, for example, flooding may contaminate water, cut power, block roads, disrupt communications, and prevent workers from traveling to reach those most in need. These disruptions can then interrupt cold change, maternal and health child services, disease surveillance, emergency referrals, and chronic care continuity. The health consequences may include diarrheal diseases, leptospirosis, dengue, heat stress, respiratory illnesses, delayed treatment, and unmet health needs. A structurally safe facility can still become a failed service. So we should look at tool 2 that I am proposing. The second tool combines technical GIS with community knowledge. GIS can show broad patterns, but residents and frontline workers identified hidden failure points: flooded alleys, isolated or bedridden residents, unsafe water sources, households without toilets, dengue accumulation sites, and roads that ambulances cannot use. In the TANSA participatory assessment, local participants, including women leaders, help generate and validate this knowledge. Communities are not only merely data points, they produce the risk knowledge system that we should be the basis for our decision-making points. So the tool 3, the proposed barangay climate health resilience scorecards, helps to convert diagnosis into priorities. It looks across 6 domains: facility safety, water, energy and sanitation, health workforce, surveillance and warning, across access and referral, and community capacity. The purpose is not to produce a simplistic label, it is to rate conditions using evidence, identify what is critical, and a guide practical investment and planning. Importantly, this is proposed discussion tool rather than a validated national instrument. So we go into prioritization. We should move from the highest hazard to highest consequence. The deepest flood is not automatically the first health investment. Priority rises when risk, vulnerability, criticality, and equity converge. For example, an area with a highly vulnerable population, the only barangay has only one barangay health center, a poor referral access system should receive urgent attention. The decision test is which investment protects the most essential health function for the people at greatest risk. So resilience is more than infrastructure. Barangay health resilience is a network. The health center is only one node. Barangay health workers provide frontline reach. Households and community organizations provide knowledge and mutual support. Barangay government provides local leadership. City health offices and hospitals support clinical care and referrals. So water, sanitation, power, telecommunications, transport, social welfare, and disaster risk management are all part of the health system and practice. Facility resilience is not the same as system resilience. So we look at now what I call the resilience action architecture. So this is composed of 1, we map, 2, we diagnose, 3, we prioritize, and 4, we act, and 5, we transform. Mapping generates a risk atlas and identifies facilities, lifelines, and referral routes. Diagnosis identifies failure chains, vulnerable groups, and capacity gaps. Prioritization sequences investments based on criticality and equity. Action builds continuity packages such as resilient water and power, protected medicines, trained BHWs, and referral plans. Transformation embeds these lessons in budgets, land use planning, data sharing, multi-stakeholder partnerships, and continuous learning. So these are the 3 questions that every barangay, which is the lowest political administrative unit in the Philippines, is that 1, when we say, when we look at, the system at the barangay level, first, where is the risk? Second, who is most vulnerable and why? Third, what must we protect first? The answer is not only health facility, it is the relationships that keep care functioning, health workers, households, water sources, drainage, transport, communication, evacuation roads, and referral hospitals continue their services and functions. Climate resilience is the ability to protect these connections before, during, and after shocks. This is a sample of an integrated community food production and social housing, shows that resilience can also strengthen food security and social support. During emergencies such as lockdowns, like the COVID lockdown, and climate disruptions, local food systems and community pantries can reduce household stress and support health. Adaptation is strongest when it connects health, nutrition, livelihoods, housing, and community action. So let's look at what we call, Metro Manila's incremental adaptation innovation. Incremental is good and necessary, but it doesn't transform systems. So we could see here that Metro Manila has developed incremental adaptation innovations through resilience toolkits, youth engagement, gender-responsive approaches, community gardens, and art-based risk communication. These initiatives matter because technical information alone does not always mobilize action. Communication, local leadership, and culturally meaningful approaches can help residents understand risk and participate in bringing out the solutions. I think we have to work towards transformative adaptation, because that's necessary to mitigate and adapt to climate risk. So transformative adaptation goes farther. It connects actionable science, climate and disaster risk assessment, risk visualization, systems thinking, professional champions, climate leaders, and public-private people partnerships. The aim is not merely to recover after each event, but to change the planning and governance conditions that repeatedly place communities at risk. Finally, barangay action must connect upward into city, regional, and national planning. Climate health facilities should inform local land use plans, city development plans, annual investments plans, regional strategies, including the cross-cutting strategies for climate adaptation of the National Adaptation Plan. These are the references on core health system, and Metro Manila sources that I have used. These notes are important because they distinguish project indicators from total risk, historical maps from current operational maps, and proposed tools from validated instruments. Responsible resilience planning requires this kind of clarity. So these are also the Metro Manila vulnerable participant planning and scorecard sources that I have used. You can find them in Google Scholar. This is my work with geographers, geologists, hydrometeorists, with people like in Germany and Singapore and Indonesian scientists, because and the title is very good. The wickedness of governing land subsidence. People don't realize that, in cities we overdraw our groundwater, therefore subsidence occurs, and it makes sea level rise impacts much more severe. Okay, so let me close by saying that I want to end my presentation with one message. Climate resilience begins at the front line. If we map risk, diagnose failure of the pathways, prioritize essential health functions and the most vulnerable, and connect barangay action to wider systems and budgets, then care can continue when climate shocks arrive. Thank you very much for your kind attention. You can download anything from my website. At the beginning of my presentation, I had the QR codes there, but just acknowledge us. But you can go to our resilience toolkit.ph, and I hope you'll be able to use some of our data. Thank you very much for your kind attention.
Thank you so much, Dr. Porio, for such an enlightening presentation that you have given us, and you have made us to understand that health facility can be standing, whilst the health system can still fail. This leading us to the resilience being more than just infrastructure. Thank you so much for taking us through the 3 tools that you are proposing, and we hope they will be taken into consideration as we move from today. So we now move on to our second case study presentation, which we are going to be given by Dr. May. Dr. May, over to you. Thank you.
Thanks so much, Thandi. And can everyone hear me well?
Yes.
Hello. Okay, thank you. And first of all, thank you, Dr. Rohaida and Dr. Irma, for setting the stage, wonderful stage, for presenting not only the framework, the concept, but also interesting and important case studies from your country. And Dr. Irma, I just wanted to emphasize the last slide that you shared. During my PhD day, I did my PhD dissertation on climate change and health. And then one of the words that my advisor used a lot is like wicked problem, right? So that is kind of sort of a flashback to my PhD day. Anyway, thank you. Yeah. Let me move this. So yes, hi everyone. You can call me May. May here. Originally, I'm from Cambodia, but I'm now based in Singapore at Singha Dugan US Global Health Institute and at Dugan US Medical School at National University of Singapore. I'm a research fellow working with Professor Renzo Quinto. I'm sure many of you have known him or heard of him. We are working on a few projects.
Climate Change Commission.
Yes, yes. So we are working on a few projects on climate change in the region and also in Sri Lanka, mainly on heat. But today, given the case study and also with the interest of time, I'm going to go through quickly through my slides. And also later on, if anyone want to reach out, I will also let the course organizer sharing my contact detail. And also thank you for the organizer for having me joining the panelists for today, for the speaker today. Okay, so this is the overview of my talk today. Gonna briefly go through, and then Cambodia is actually part of the mainland Southeast Asia, the Mekong. So we will start with understanding some landscape, and then just a picture of climate. Cambodia healthcare structure, and then some major climate risks, vulnerability, and then particularly the health system challenges, and then what are the Cambodia's strategic direction that we aim to address those challenges. And lastly, I just want to share a few slides on my current project in Cambodia, in particular on heat and mental health, physical and mental health among farmers in Kampot province, is one of the coastal area. Just set the stage. We are at around close to 17 million population, based on 2 years ago. Quite rapidly aging as well. Economy is like lower and middle income. Health insurance coverage on a combination of private and public coverage, I would say close to 60%. And then the ND gain rank is 127. So for those of you, ND gain is the index is the from the University of Notre Dame Global Adaptation Initiative. So they actually combine looking at both two sector, two score or two theme. One is vulnerability score. There are detailed calculation. You can also click in the embedded link to explore further. And then also a readiness score. For vulnerability, a higher score means more vulnerable, and then a readiness higher means more prepared to adapt. And just want to compare within ASEAN. Cambodia is a tie with Laos, Laos PTR, but doing better than just Timor-Leste and Myanmar. So we actually among one of the vulnerable within the region as well. And then if we look at our healthcare structure, it's actually this is a sort of like a simplest summary. So we have national level here. And then subnational. So if you look at tier 1 would be the first sort of like first catchment. Predominantly we would have health centers, but in some remote provinces, we would still have health posts. So at the health center level, there may not be a medical doctor, although on paper there should be, but not every health center has a medical doctors. So some health center would only have nurses and stuff like that. And then go up to referral hospital, and then move to provincial level. We also have provincial referral hospital, and then regional training center, etc. And then to the tier 3 national level, we do have national hospital, and then some training institution, ministry, health department, and other national centers. And just want to mention, a lot of time, the first front line, we call so-called front line, the level 1, are the most vulnerable and least ready when it comes to climate impact. Because prior to working on the project that I'm going to talk later in the slide, I also have done some work in Cambodia for a number of years, and predominantly we will go into the provinces, rural area like health centers. And some of the health centers, they don't even have access to a steady or regular electricity. So yes, I just want to set some stage. And now talking about major climate risks, because if we look at the temperature changes, mean temperature changes compared to the 60s, it actually, Cambodia have increased almost 1 degree C, which is a lot. And it is projected to rise up to 2.7 in like 30 plus year. And then by 2090, the worst case scenario would be 4.3%, 4.3 degrees C hotter, which we could not even imagine, because I believe now heat is affecting us everywhere, not just in Asia, but also in Europe, recently with heat waves. And then the rainfall pattern has becoming quite unpredictable, I would say. Data also show that it's more intense, and also the variation, it's actually the dry season is actually longer, and then because of that, we would have patches of places in the country whereby it would be drought, and then another places would be flood, especially flash flood. And in the city, in our capital Phnom Penh, also flash flood is quite common, especially during rainy season, which is a monsoon season, which is now, and also heat wave. Coastal region, we do have 4 provinces along the coast, and they do experience sea level rises, and then saline intrusion and storm surges. And I just want to mention that coastal region, although we have 4 provinces, back when I did my PhD around 10 years ago, I actually got some funding and went to those 4 provinces with some research assistant to collect data on climate change adaptation and health household survey. So we interview close to 2,000 households, and after data analysis, we found that actually, although they may live in the same so-called coastal area or even the same province, they may not have the same number one impact. Number two, the way they can adapt and their resiliency. It really depends on their socioeconomic. I think like our previous speaker also mentioned as well, if you are already vulnerable or you are a marginalized population, then when climate hazard hit, you are put you in a worse disadvantaged position. And also climate-related mental health is also a major concern, especially among the vulnerable. But yet, mental health and climate change has not been the most studied subject, not only in Cambodia, but also I think in general. Some health sector vulnerability, as I mentioned, is sort of linked. So vector-borne diseases, dengue, malaria. Although malaria has been down, malaria cases has been down quite substantially in Cambodia, but still remain in the northeastern region, like among indigenous group. However, dengue cases actually right now there has been outbreaks because it's a full-blown monsoon season. So far we have I think close to 60,000 dengue cases and close to 80 deaths already this year. And then waterborne and foodborne diseases, poor wash infrastructure, especially in rural area, sort of like put vulnerable people for diarrhea or foodborne diseases, and especially during flood and also drought. And lastly, extreme weather event, as I mentioned earlier, either flood or drought and heat wave worsen health outcome, and that would impact the direct impact or indirect on their nutrition intake and also mental and well-being. And for health system challenges, we do have, because in Cambodia, although we do experience intense climate change problems, but because our health system is not ready, or so like the priority with limited resource, we could not sort of provide spotlight climate change or put climate change as a forefront in terms of addressing the health system. So we do still have limited climate and health data integration, which is an important step, like Dr. Emma shared earlier, right? When we have data, we can overlay, do some GS analysis, and then we can also come up with the, strategy to address those. Inadequate early warning system, we also experience that. And then among health workers, as I mentioned earlier, especially in the front line health center, some we do not, some health center, there's no even a medical doctors. Vulnerable in health infrastructure, when flood hits, those infrastructure, road got cut off, and then people could not access to the health center, and also if power line knocked down, there's no reliable backup generators. Insufficient climate financing is also contributing to the health system challenges. And lastly is the weak integration climate risk into health planning and budgeting. But despite these challenges, our government trying their best to address, those challenges by setting this direction. For the interest of time, I would not gonna read through this. So these are the strategic direction that we set to address the challenges. But I just want to spend maybe the last 1 or 2 minutes talking about our project. We just collected data last 2 months ago on mental climate change, heat stress predominantly, fighting physical and mental health among farmers in Kampot. So this study, we have 4 objectives. Number 1 is to evaluate the readiness of health system respond to heat-related illness, specifically focus on heat and assess physical and mental health impact of heat among farmers. And then we would also do co-design community-based heat resilience strategy, and we'll come up with a toolkit. And ultimately, we would aim to inform a national policy in terms of climate change adaptation and planning. So these are our methods. So we actually interview 380 farmers, rice farmer, salt pan farmer, vegetable farmer, using these tool, validated tool, and then capture their satisfaction, their anxiety, their stress, knowledge, attitude, and practices, their self-related health, chronic diseases, and the demographic question. And also qualitative interview with farmers and some key informant with key stakeholders, including the ministries. And next step, we would do participatory workshop to co-develop a resilient toolkit with farmers and healthcare workers. And these are some of the pictures we took during our trip. And I think I'll end my presentation here. And please reach out to me if you have any question. And thanks once again.
Thank you so much, Dr. May, for giving us your presentation, and you've made us realize that some of the health system challenges really lie within us, it really lie within us failing to ensure that our work is consolidated around all those areas where we can get the data. That's, you termed it, the lack of consolidated climate data sources. And then you also identified vulnerable infrastructure as one of the causes. And then thank you so much for also bringing into perspective the issue of mental health, which of now it's still coming up in the issue of climate change and health. Thank you so much to all the speakers. I just want to squeeze in just a few questions to all the speakers. If I may go through the questions and then you'll answer after I've asked each and every one of you the question. So to Dr. Rohaida, I have 2 questions for you. Is there a repository or a database for all or some of the 5 assessments that are depicted in your presentation? And if yes, how can they be accessed? And then there is another question on, can a climate risk assessment itself become a human rights accountability instrument that is identifying not merely where climate risk is highest, but who bears that risk, why they bear it, and whether government has taken reasonable measures to protect that. And maybe the last one, can the Vital HCF model be used as a metric for identifying funding gaps in the healthcare systems? So those are the 3 questions that we would like you to answer before we can end today's session. And then for Dr. Poria, I have one question for you. It's on how do seasonal flood pathways in the Pasig Marikina River Basin alter the spatial distribution of waterborne and vector-borne diseases like leptospirosis and dengue in informal settlements? So those are the 4 questions that I'm posing.
Question? I did not get it.
All right. The question is, how do seasonal flood pathways in the Pasig Marikina River Basin alter the spatial distribution of waterborne and vector-borne diseases like leptospirosis and dengue in informal settlements?
Okay.
And maybe another question will be on, will you be submitting your study to the National Adaptation Plan of the Philippines?
I was part of the crafting of the National Adaptation Plan. I insisted on the cross-cutting strategies, infrastructure resilience, livelihood resilience, ecosystems, empowered local governance, and nature. cross-cutting strategies. Intersectionality of vulnerabilities means you have to have an intersectionality of adaptations and investments. Thank you. Sorry.
All right, thank you. And also to Dr. May, your question is it possible to get the results of your study? So these are the questions that we would want all of you to answer, depending, hinged on the presentations that you just gave us. Maybe we can start off with Dr. Roheda.
Okay, thank you, Tandy. For the repository or database, I'm not sure. Is it about the 5 small islands, I assume? So we don't have, we don't share the repository because it is based on the funding that we receive. But then you can email to us if you need to get something more about the study, especially on the ICOV, the coastal vulnerability assessment. And the second one about from Darwin, I think, can a climate risk assessment itself become a human rights accountability instrument? It could be. Because for especially for the community, the climate risk assessment we do at the household level, so we can identify specific to the individuals, especially the head of the household. But okay, because the risk it depends on the exposure that we identify the small island based on the population size and also the location, and those who are bearing the risk are actually the population itself. So why they bear the risk? We know that some of the small islands, it is not a developed island as compared to larger islands. For example, in Malaysia, we do have Penang Island, which is an urbanized islands. They are developed, so the risks are relatively lower as compared to the remote area. And yes, the findings, we are communicating the findings with other agencies as well, especially to improve the adaptations in terms of education, the social, the infrastructure, and also the access to health services. For example, some of the islands, we do have mobile teams for medical and health services that they go to the island on some regular basis, so that the island population would have better access to healthcare services. Okay, and I think there's one more question. I think, can the vital HCF model be used as a metric for identifying funding gaps in healthcare systems? Right now, based on our questions, we do identify the exposure, sensitivity, and adaptive capacity, but the questions do not detail out about the funding gaps in the healthcare systems. Perhaps this is a good input for the future implementation of the vulnerability and adaptation, so we could incorporate the finance gaps in the healthcare systems. Okay, that's all the 3 questions. I'm not sure if there's more questions, but probably I will answer by in written for other questions. Okay, thank you, Tandy.
Thank you, Dr. Roheda. for answering the questions. Dr. May, if you may come in.
Yes, thank you so much, Tandy. Yes, because we are now analyzing our data, we would for sure would share. I'm also personally interested and curious to see what we collected, and yes, certainly it will be circulated in LinkedIn or through channels. So yes, yeah, thank you for the question.
Thank you, Dr. May. Dr. Porio?
Yeah, thank you very much for the question on, the flood pathways. Let me say that in the two facts. One, in Ondoy or Kitsana, 476 people died of leptospirosis, and a WHO official told me it's one of the highest. But that's one, we have the highest leptospirosis incidence. But I would like to just point to you that in Kitsana, 1 month rainfall fell in 6 hours. That's in 2009. But last year, in the August 30 floods that flooded, including my campus, 1.5 month rainfall fell in 3 hours. So of course, infrastructures really get overwhelmed. But one thing that is really important is that for example, we made a climate disaster risk assessment of community facilities, evacuation facility in Marikina, because the question is about Marikina's, a flood pathway and a failure like that. Basically is that when we look at all evacuation centers, 90% were in flood-prone area. That means they get inundated and then you have the evacuation center there, and then but the only one that was not flood prone was sitting on top of the earthquake fault. So I always say location, as the real estate people say, location. Marikina is located in the bottom of the flood basin. So I always say, if you're there in the bottom, you either have to evacuate, get out, or, so I always say location, context, and so it's very important that, so I would say that risk profiling, before you invest in something, before you decide, is really a very important, base for decision making. The risk profile, who is exposed, what is exposed, what's the capacity, very important, but oftentimes that flies out of the window in terms of the planning, in terms of the investments. So, thank you.
Thank you so much, Dr. Porio, and to our presenters. Thank you so much for such an enlightening session, and we encourage that these discussions can continue beyond today's session. And for the participants, if you have got a burning question to our presenters, you can request for their email so that you can continue with the discussion. And my apologies for us going a little over the intended time. We thank you so much for today, and we look forward to having you next week in our another enlightening session on the solutions, the health system preparedness.
I want to thank my co-panelists. I learned a lot, and I would like to get your PowerPoint. Thank you, Dr. Rohaida. I really, and all the presenters were really great. So I mean, it's always great when you learn something new, and I learned from this one. So thank you.
Thank you so much.
Thank you. Bye-bye. See you in
Thank
another.
you. Bye.